Hello, everyone. I have to apologize. I've never actually been the center of attention in a webinar, but I will do my best. Anyway, so what I'm going to talk to you about is how my clinic has launched on this, and actually, people actually enjoy doing it, which is always great when you have a bunch of doctors and residents who all come from different points of view. So first of all, I'm sure that everyone is familiar with the ASAP recommendations, these screening maneuvers. Basically, we've created a workflow in the office that allows my staff to help the doctors perform these maneuvers whenever a patient presents to the office and time allows. So we as a group have decided that we're actually going to pursue all of these things, but we've started our age at 21. So first of all, I could show you the actual screening tool, but there's a few things that you need to establish before you begin the process. First, you need to create a screening medical band in your patient history. So this is just a screenshot of the sidebar, which shows history of problems, surgical history, and then we've added screening into ours. That's something you can do from the administrator can do from the system settings by customizing the patient history. And you need this because you need the tool to be able to draw in information from somewhere. It can't be randomly placed within the chart. It actually has to be put somewhere. So first of all, you start by doing that. Oops. Oh, what an amateur. I'm so sorry. What happened? Sorry. What's going on here? Come on. I'm sorry about that.
It's okay. So I'll have to admit that sometimes the your system might behave differently when Citrix is running like this, so it just might be new.
Is that right? Yeah, because it's not letting me get back to that. Come on, show slideshow. That's just it was working earlier. Okay, that's weird. Okay, so then after you've created that screening band, you need to do a query for your staff. And what we've done is created a query within the reports that is for any patient over the age of 21. And the reason we picked 21 and not 18 was because the 18 to 21 requirement is basic vitals of blood pressure, weight, and height, which as a rule we have in the chart. And my staff, that's what they voted for, was for the over 21. So we get one of the staff will do this every day for the next day, looking for patients over the age of 21 who are actually active patients and that their appointment is the next day. So then this is an example that you would pull up for the next day. In this situation, there's 31 patients that qualify. And so one staff member goes through this list and does the screening that needs to be dropped into that screening band within the patient's history. So in that screening band, in our screening band, we have lots and lots of things. We found this screening band to be very useful, so we've added all sorts of fun stuff in there. But only the starred items at the top are the ones that my staff actually seek out within the EMR to actually place in here. So they find, for example, so what happens, this is the protocol that my staff go through. They search for the parameters within the virtual chart, and this is an example of looking for a fit test. Basically, the screening maneuvers, fit test completed over the age of 50. And they go into the virtual chart and actually type in fit, and Calgary Lab Services, actually, that's how it comes in as FIT. And if nothing comes up, they also look for occult blood, because obviously that was the screening of choice just over a year ago. So they locate the document and they note the date. And they return to the EMR in screening. They click on the plus within that screening tool and add the date. And then they save and close it. They will also write in that it's negative or positive within the information associated with this. So now, how does a busy doctor know that, this is kind of a busy slide, I apologize, but how does a doctor know that they should be doing the screening? So what we've done is when that person, the staff person has completed all the designations, she has a list of things she has to look for, and it depends on age. Obviously, you're not going to look for a fit test in a 21-year-old, but she knows by age what she's looking for. Once she has completed that, she goes into the appointment status, and we've created a status like I'm showing here. That's in the same one where you put, a patient arrived, patient no charge, no show, that kind of thing. And she clicks on the screening completed icon or choice here. And then in the scheduler, the patient shows up. We've put a black triangle, so it's really obvious that that patient is a reminder to the doctor that that patient is ready for screening. It also shows up in the doctor's day sheet. It shows a black triangle, so in their day sheet, and in the appointment history, there's the black triangle. So it's just a nice reminder for the doctor that, hey, maybe I should open the screening tool because somebody's looked for all those things. So now the last thing is you need to customize your patient's physical, because there are some things that you can add to vitals that when your staff are doing blood pressure, weight, and height, that you can also include in there. So that's just adding things to the physical history, and the staff can ask these things because they're quantitative. And these quantitative things become lab results, and they are very easy to pull into the screening tool, which is a chronic disease management tool. So we've added exercise. So obviously the most important ones that normally come in would be blood pressure, weight, and height that you would normally do. But we've added in waist circumference, which we get for patients over the age of 40, which is not one of the screening things, but we've added it in. And we've also added exercise, tobacco, and alcohol. And so those things will be automatically done at a physical or individually, a doctor, or you could have the staff do it at any visit, but for sure we're asking that. We also ask at the physical tetanus and influenza vaccination, and both of those are added into the screening band that we talked about. So well, coming back to this tool, so what I've done here is shown you that the day of the visit, these top 1, 2, 3, 4, 5, I think there's 8 or something, are done the day of the visit. The Pap test, the plasma lipid profile all come in automatically. I mean, the Pap test is done the day before, but my staff, they look for it. The automatically from labs, you get the lipids. The doctor, unfortunately, has to actually do a Framingham risk score, so that one needs to be added in to the screening tool by the physician. And then, obviously, diabetes comes in automatically. We have not done a diabetes risk calculator because that isn't something that we're not sure we want to do at this point. It's not an easy thing to incorporate. And also the day before, these last two things, the colorectal cancer screening, all that has been done the day before in the mammography. So really the only thing the doctor has to enter themselves is when they do get lipid profiles, they'll have to add the screening that they've done to the screening tool. So now I'm going to move to Accuro and actually show you, Accuro, where are you? I'll close this. Quick PowerPoint. So Accuro, where are you? Oh, now it's logged me out of Accuro. And just show you the tool that we're using. I don't know if anybody has actually used a chronic disease management tool. That really does help if you've had some familiarity with that. Barb, can you see my Accuro right now?
Yes.
Okay. So this is Minnie Mouse. She's a test patient in our office. And so when all the chronic disease management and our screening tool is at the very bottom of forms. They're called CDM worksheets. The only active ones we're using right now are the diabetes one and the screening maneuvers for adults. So I'm going to click on that. And when I first open it up, please don't all faint if you haven't seen one before, because it's kind of, oh my God, it looks amazingly complicated. So it's opening. So it was, oh my goodness. So we have a lot of extra things in here, things that we routinely ask in the clinic, which do not need to be done by everyone, but these are things we always ask. We have some general things about relationship and domestic violence. That's not obviously in the screening. And we have a few other things. And the reason, though, is we've taken everything that we could out of the physical template that could be quickly done by checkboxes that we always did. So we've removed as much as we can from the physical templates and put it in here so that this could be used as a tool, not just for screening, but just doing lots of the things we like to do as physical. So the first thing is you need to click on the select recent values. And these will be all the things that are in this screening tool here that apply will be drawn in. Also, things from the physical, like, for example, how, that's not a good example, but well, things like exercise, etc., will come in from there. So anyway, let's go back here. So the first thing you do is you click on select recent values. And if you've done it right, everything that was red will now become pink. So here you have the most recent blood pressure has been pulled in, all the waist circumference, exercise, tobacco, etc. And then we have a few extras, street drugs, marijuana, contraception. The menstrual history is only in the women. They're in the screening tool. You can choose, when you're designing it, you can choose to apply things only to men and women. So I'm only showing you the women's version today, but the men's version just doesn't have the menstrual history and doesn't have PAPs and mammograms and that sort of thing. I can probably pull up a test patient and show you that if people are interested, the male version. So here going down, we have tetanus vaccination, and it's really important that we, Minnie Mouse had hers in 2011. We can also tell her advisor of the 10-year recommendations. We can, if she declines it, she doesn't know, then we can give her, the number to contact to actually get that done. Influenza vaccination, she had hers. She's already had it for this year, but and we can advise patients. There's also opportunities that we're looking for to tell patients the recommendations. The same goes for Pap tests. Obviously there are different screening intervals. Some people are no longer require it because of whatever reason, or people might decline it. Some are getting colposcopy. In this situation, her most recent Pap was in April, and she's due in 2017. Diabetes risk, you can choose. Obviously, screening is not meant for a high-risk individual, so as soon as you become high risk, you leave this diabetes section and go to a different go to chronic disease management. But the rest of the screening tools apply. I put these in order, so if you're looking here, this Pap test goes 21 to 69, then 40 plus. We are doing hepatitis screening in the 1945 to 65 birth year, but it was easier for us to have the actual age of the patient. That's a recommendation we've been following also. So as you're going down, the age goes up. So if you're 50, you're going to stop here. If you're 40, you're going to stop at diabetes and go from these are the recommendations. And I put the recommendations so that people can easily and quickly see that. So, and then you go down, we've added hearing assessment because that's something we always like to ask. And mammogram, average high, obviously you're high risk, you leave this. Colon cancer, average high, obviously you're high, you leave this. And we did put osteoporosis in here because we have been following the recommendations for osteoporosis also. So that's the screening tool. And actually, it looks intimidating the first time you see it. And once you've used it a few times, the doctors actually really enjoy using it. They feel like they do as much as they can when time allows, but all the just quick clicking make it very easy for them to use. So that's our screening tool. So I'd be happy to entertain any questions that anyone might have, or if it wasn't clear what I was talking about. That's pretty quick, 20 minutes. I must get an award for that. Hopefully it wasn't too fast.
Well, let's go to questions from participants. So you can either ask your questions by taking your line off of mute and asking by audio, or if you want to remain anonymous or have me pose your question, you can write it in the questions area of your GoToWebinar control panel. So while users are thinking about their questions, Dr. Walsh, I have a question for you. So when you first presented this to your colleagues, and tell me about their experience from using it initially to having had some experience with it for a few months.
Well, like I said, when I first opened it, the reaction I was expressing, please don't have a heart attack when you see this, is pretty much the reaction. They're like, oh my God, what have you created here? But because I removed so many things, a lot of these things were in our annual physical, and they weren't something that was easily followed. You couldn't follow it, you can retrieve it. This, you can quickly look and see that you've completed a task, like you completed the screening, and it shows up, it's easy to find. And even the nurse that came to do our assessment for ASAP, and then looking at what we've done now, it was quite happy that this was so easy. All she had to do was open up the screening tool in the patient's chart, and she could easily, quickly see what things were offered and what wasn't offered. It pulls up everything that's recent. So it was, and someone else can follow it really easily. You can see previous ones, like if you wanted to compare to last year, you can compare, like we're in the most current one, which is today, but then there's other ones in the past. So in the visit, you can quickly look and see. You don't have to ask the tetanus question again. You can look and see that, it's been asked. But generally, those things are being drawn in from the screening tool anyhow. So the screening band. But yeah, people do react kind of like, oh my God, when they see this at first. But now they're really happy with it because it has unified our practice and it has made them very efficient. So there you go.
Thank you. Do we have any other questions from people on the line?
Oh, hi, Dr. Walsh. I was just wondering, you were just saying that it's made you, that it's kind of unified your processes. Do you find that your staff now has more time for other things, or they're kind of getting more proactive in other areas because everything is unified and they don't have to learn different things for different doctors, or did you? Well, we're
pretty, as far as the group goes, we reach consensus and go from there. So our templates have really, like I can show you templates for, let's go back here. Like our physical templates have really, I'll just pull up here, like our adult physical template. Everybody uses the same template. There isn't like my template, your template. How undressed you get a patient. We've actually really unified our practice because it's just too hard for staff to know everybody's little quirks and whatever. So even things like what age do we start taking blood pressure at for children, or how undressed do you want an adult male, that kind of thing. Everybody follows the same thing. So that's made it pretty easy to follow. So you can see here in this, this is an adult female template. I used to have templates for every age group by 10 years. So I had 20 to 30, 30 to 40, 40 to 50, 50, blah, blah, blah. And now we have screening maneuvers for adults. So it's another, a place where you're reminded to open that and go through it. So we used to have well, we still have quite a bit of stuff in here, but we used to have all that typed in here in these clickable things, all those things about domestic violence, and all the questions about diabetes and colon cancer screening, that sort of thing, were all in here. Here we're still putting like what we're ordering and everything, but we use all the same templates, so there's no variation there. So it's really easy for my staff. They just do the same thing regardless of the doctor. But that's not always that easy to get people unified in practice.
Yeah, do you have any tricks to getting that happening?
Well, you know what, I think that the biggest thing that has worked for us, you know, over, I mean, Salveo's been around, we're in our 9th year right now, but we do continuing ed at lunch every Monday, the physicians, and that has been central to us unifying our practice because we do those McMaster small group things, and so there's recommendations that come out of those things, and it's like, well, you know, what are we going to do? Are we going to do this or aren't we? And so over time, that's unified our practice because we all see, you know, talk about it, we argue about it, and then we make a decision, and I go in, I change the template to accommodate it. And so everybody agreed to do the screening thing. So when I pulled this up, I mean, I think they all had a drink that night, but I think they all pulled themselves together to do it. But, you know, I think they realized, and it's so much nicer when you actually see it, you know, your colleague's patient, that, you know, they're doing the same physical you're doing, and they've got the same template. You can open it and you go, voila, I would do the exact same thing. But to me, the key is conversation and continuing ed. That has been, and the residents too, because we have 5 family medicine residents. They're in the same boat. They don't have a choice. And anyways, that's how we've unified our practice.
Oh, that's great. I'd have to say there's something about strong leadership that's worked as well.
Yeah, they don't have much of a choice.
Well, yeah. But obviously you're a clear leader, so that's great.
Thank you.
Dr. Walsh, let's go back a step in that you want to do screening on your paneled patients. So even if, let's say, your practice is closed, you might occasionally take a temporary patient. What are some of the tips that you might have for other Accuro users to know who are their paneled patients and some of that verification that you do with your patients that they are a member of your family practice?
Okay, well, right now what we do is patients that have been in the clinic that have not transferred their charts, etc., just have been to the clinic within the last 3 years are considered active patients. But as of the year 2014, because we were doing this, we added in status called Active 2014, and that is a color status that it makes the Active 2014 means demographics. The patient has been asked, you know, you're coming here, your doctor is this doctor, your phone number is correct, your address is correct, you know, all those kinds of things. And so then they're made active 2014. And the goal is that every single patient that makes an appointment needs to have that particular status. And we're actually doing a telephone confirmation thing run with Accuro right now. And my staff actually asked to enter in, along with that, how a patient wishes to be contacted for confirmation of their appointment. So there's a lot of reasons that they update it. So in the patient profile, patient tab here, we have, well, Minnie Mouse is permanently archived. She's not a real patient, but so we have active in this bright green and active 2014 in bright green, and this active. Active is anyone that has been in the clinic in the past 3 years that we have not had the chart transferred. They, as far as we know, are still coming, but the active 2014 are all patients that have had actual confirmation of their status since January of 2014. So those we can easily pull up, but it's, you have to get your staff to buy into checking these things with everyone, because we had, before we went with this, plan to address our panel, it was pretty much, if you sent a letter out to 100 patients, you get 50 back, it's moved or incorrect address or something. So we've had a real, and I regularly go into reports and I pull out the after 2014 and we see where we're at. How many patients have, we can quickly look at, I'll close it really quickly so you won't see any patient names, but, keeps going up. So they're at 4,191 patients that they have actually confirmed their status. And next year, it will add in active 2015. So that'll be another status that will be there. So as of 2015, they'll do the same process and move people from active 2014 to active 2015. But the only way is to ask your patient, unfortunately.
What are some key messages that have resonated with your staff to get buy-in on managing the patient status process?
Well, I think the big thing is that they're helping the doctor be more efficient and more effective. And actually just speaking to physical exams, these things, getting all these numbers, the doctor doesn't have to look, so when was your last blood work? They open the screening lab, it shows 2013, depending on what we're screening for, a clarity of when that happened makes all the difference, or when their last pap smear was, those sorts of things. So the staff now are working, we've talked about this in our staff meetings, is that the reason we're doing this is to make the doctors more efficient and make them able to do more at a visit and, and provide all-round care. My thoughts for the whole process are that actual physical exam is actually going to eventually, probably in my lifetime, an annual physical will no longer be a paid thing, because, every recommendation comes out tells physicians that no, they should no longer be doing, a breast exam unless there's a symptom, etc. That actually our job is going to be screening and prevention, and so you better jump on the bandwagon and get in there and get your feet wet, because this is going to be the future of family medicine. That's my belief. So that's why I was so keen, and that's why I've instilled it within my staff. They know it's part. This is going to be what we're going to be doing as family physicians. So, but maybe I'm just a crazy person, but I think the information is out there, and that's what we're trying to do, jump on the bandwagon. So I think staff appreciate being part of something and understanding it.
So they feel they don't feel like they're clinic admin staff as much as being able to contribute to patient care for the patients in your clinic.
Yeah, well, we're trying to work as a team and try to do the best for the patients, and that's the philosophy. They're working with us. They're there to help the physicians be the best they can be, and that's an important job, and that's the job I feel I have. I feel as the leader person that I'm making efficiencies and workflows that help my doctors be more efficient, and they can accomplish more, but not with more time spent. So this tool has really, I think it's just like anything. You think the first time you use an EMR, it doesn't seem like it saves you any time at all. But once you get your handle, get it going, it's like, wow, this is a great tool. And so adding in the screening tool, and so now I'm really keen to add in some of the chronic disease management ones. Some of the background work that you have to do to link. You don't just download that and run it. There are some things that are linked, but most of the things you have to actually find the items that you're going to link it to. So if you have tetanus in your that screening band, there are, the actual item that you fill that says influenza vaccination, you actually have to link those things. So there is some background work, but once it's done, it's done. So, because the downloads of these chronic disease management tools are, some of the lab work automatically links, but mostly a lot of the, like your tobacco, et cetera, that's going to have to be linked. But it's not difficult, it's just you have to know how to do it.
So on that note, you've done a lot of linking of data and information in the system. So if you wanted to, you could run reports to determine your overall screening rate for mammogram, let's say.
Yeah, well, you can definitely search for that because we've entered it into an item in the screening band. So I haven't actually done that, but I'm sure it can be done.
Yeah, I'm thinking you could do it with the query tool because the data's there and it's well organized.
Data's in the screening band, yeah. So it's like any other searchable thing. If it can be brought into this tool, it can be searched for.
Okay. Do we have any additional questions from users on the phone? You can either ask it out loud, or you can use the question tool in your GoToWebinar control panel.
Was excellent. Thank you very much. Very, very much.
Oh, thank you.
Questions might still come up. We also have on the line and participating from QHR Accuro is Brad Reben. So if anybody has any questions for Brad at Accuro, this would be your opportunity to ask that now as well. And I think, Brad, an obvious question might be is how other users might be able to get access to the tool.
Right. If the clinic isn't already set up with an administrative user, a call to our client services can, have somebody designated as the clinic admin, given the system administrator permission, and then, at that time, client services can also give a quick run through on the additional functionality that entails, like Dr. Walsh showed us. They have the ability to configure the CDM worksheet as well as the medical history. That's kind of such as that.
Thanks, Brad. Any other questions?
No, more of a comment, Barbara, just the flow of the template in chronological or in age order really works for my head, so thank you very much.
Okay, thanks. Yeah, it makes it easier for the staff, and I put those little, the age by even the screening bar over here when you go plus. So when my staff are looking for things, they can see it's over 65, it's over 50, just because. And then the hepatitis C screening thing, next year I'll change it to 49 to 69 or something. But it's just, Pat, how old, so that, they don't even have to think, oh, this patient is, only 18, I don't have to do this or whatever. But I'm trying my best to make it easy for everyone. So,
Just and on that question though, making it easy, because there sometimes are exceptions. So if you've had a patient, for example, with a bilateral complete mastectomy, she might not be due for a mammogram. So do your staff know the exclusions for things like that?
Well, they're not really looking for that. They're just looking for the mammogram, all she's doing. So basically it would be, the easiest one, and go into here, would be, I would say, you have to know what things are called. And in Calgary Lab Services, PAP, you can search for PAP. So this is what she would do. It's called cytopathology. So she just searches for cyto and looks for it. Well, Minnie Mouse has never had a pap smear. Shame on her. But so normally it would pull up whatever, 5 of them, whatever, and that all she's looking for is the date of the last one. She's not looking to see was it normal, abnormal, does she now get colposcopy. That's something that the doctor hopefully has entered in their history of problems or their surgery, but when they do open the screening tool, that's when that information, there's, I'll just open it again. Screening. There are spots to put, for that it's no longer required, mammogram declines. Gee, I don't have a spot there that it's no longer required. Or actually, there's different screening things that involve. Once you become a high-risk person, you need this, right? So somebody has a bilateral mastectomy, screening really isn't applying to them in the same way. Usually they're having an MRI or something. So one thing I've emphasized to my doctors is once you become high-risk, a screening tool no longer applies. Even the Framingham does not apply to somebody who's on lipid-lowering agents. Like, you don't do a Framingham anymore. You're basically looking at the parameters that you get from lipids. So that's one of the most important things about a screening tool. It's not meant for the high-risk individual in that particular disease, so diabetes. Once you actually have diabetes, you don't go through this part. You skip over it. It's no longer pertinent. Once you've had a heart attack, you're not using Framingham risk scoring anymore. They're high risk. This no longer applies. Once you've had breast cancer, this mammogram thing no longer applies. Once you've had colon cancer, you're in a different set altogether. So I don't think screening tools are meant for high-risk people. So in that situation, that would be where you would use the diabetic chronic disease management tool, which I'm just working on. I can show you it, but it's got some work to be done. So if Minnie Mouse here had actual diabetes, there would be a difference. Every 3 to 6 months, she gets other things done. But you would go to a different type of tool because you're leaving low risk now. So that there are chronic disease management tools for that's actually in Accuro from Ontario, I believe, but they do need a little bit of work as far as I'm concerned. But I'm working on the diabetes one now that I've had success with the screening tool. So.
I just want to go back to the screening sidebar that you have under medical history.
Yeah.
And the value, so you see everything there, you've got a quick view of dates.
There's, like in here, we've added everything. I added all sorts of things to see that they would enter into the screening tool. So there's things, everything's in there. So go ahead, sorry, I didn't mean to interrupt.
No, just in terms of usefulness of that. So you've got quite a long list there. Does it continue to populate, and then you'd need to scroll through it?
Say that again, I'm sorry.
Let's say a patient's been doing screening for, they're quite elderly, and does that get quite long, or could it get quite long?
Yeah, I guess, these are all the screening things that we have in there. Minnie Mouse's is the biggest list I've ever seen because everything's filled in for her. But some of these things, it doesn't really matter that it's big, some of the things like an ECG that she's had one and it was normal, those are just quick things, so I never have to go and look in the virtual chart and try to find it. Celiac screen, again, do I really want to look for that? Once it comes in, I'll just put whether, she or she's, I can put today's date and I can put negative, save and close. So now she's got celiac right in here showing up as negative. So it's a test that it's not in any template, it's not in any screening tool, it's just information. Some of the other ones, echocardiogram, Holters, newborn metabolic screen. I mean, that'll go in once and never be entered again. A lot of these things are just because once you've done it, hopefully you'll never do it again. So those bits of information just make you more efficient. If you're doing your labs, you quickly see that, you quickly enter today's date and it's negative. We just are trying to make it so that we don't ever have to search for things again if we can help it. Obviously, it's still going to be situations, but.
Okay.
So we've added this other bar too. This is another customized bar we've added as consultants, and that one we also find very handy. The patient that you get a referral in, it's so quick. You last saw Dr. Adams March 18th or whatever. We found that to be helpful too, so that we don't have to search around. We can easily find things.
Yeah.
But I think my obsessive compulsiveness is showing right now. It's not something I'm on medication for, so I think it's okay.
Well, I could see that consultants column would be very handy for ASAP in knowing which patients have had a colonoscopy.
Yeah, well, just who their specialist is, what we put that in just so we know. And if a specialist wants to see them every 6 months, we can put that, every 6 months in there so you last saw them in June last year, you're due this June or whatever, right? So we've added, you can do all sorts of neat things. Like I think you're not stuck with the standard, and you can move these around. I'm sure people know that. You can change the order. This is the order I have in mind, but my staff all have screening at the very top. And you do that in your user preferences over here. And you can, for my staff, what are the things they're looking for? The screening. So we've moved all of theirs up to the top. So it's the first thing they see. They're not going through all this other stuff to get there. But you can reorder this to whatever works for you. And for doctor, I don't need screening at the top, but my staff really like that. And so we made their chart view look different just to make it easy for them. So they have screening at the top and consultants below it because they're the ones that enter when they were last seen. So any referral that comes in, they enter the type of specialist, who it was, and the date when that patient was seen. So you can customize how that order is and displays over here in this EMR workflow. You go to this configure medical history band, and you just move things up and down where you want them. You can put whatever you want. These are created elsewhere, the additional ones, but you can move in any order you want. So that is something that making it just that they don't have to scroll down, especially if somebody has a huge medical history. There's some people that have the whole screen view of just the medical things wrong with them. Then they have to scroll down through everything, if it's at the bottom or something. So we put it easily so they see it right away. They do it. There's no scrolling. It's great.
Great. And just the question too on your process and feedback for doing that, does that happen at staff meetings? You have your Monday CME meetings, which I would take are physicians. And this is the type of activity that's discussed at staff meetings?
Yeah, what we do is most Wednesdays at lunch, we do a short staff meeting. Usually it's something like, we'll talk just about screening, how we're doing it, what the process is, and they tell me the issues they're having. I fix them or we adjust things if they don't understand, and then we change things, and then we'll go around, and a lot of the staff don't have the skill to move things around, so the office admin will go around and actually fix it so that their screening tool is at the top. Just go around and see everybody and fix it. Like just go in and make it more efficient for everybody. So we usually do that as a full run. Like, one person will go around and fix it on everybody's desktop so that they aren't having to figure that out themselves. And that happens for, anything that we change. We have meetings almost every Wednesday at lunch, and we try to keep them short. How do you, document? How do I want them entered? How do you put consultants in? Like, how do you do that, right? Like, what are you entering? What date are you entering? In the documents, filing documents, I mean, that's a very particular thing. Like if appointments are coming in for specialists, how are you notifying? How are you documenting? So that appointments don't get lost, the patient doesn't show, those sorts of things. So that's what we do at meetings with staff on Wednesdays at lunch. So I pay them through every lunch, but that allows me to say, you take your lunch with me and I will do something. Like this week we did, yesterday we were working on complex care planning stuff, we're doing another thing where we're pulling in patients that can have a complex care plan. So things like that, where we sit down and we talk about it, how are we going to do this, and then launch on it. So change is inevitable at the Salveo clinic. So I think if you don't like change, you don't last long as a staff member. So because you have to like new things, and that you're working towards efficiency and comprehensive care. So.
Great. Well, that's good to hear. Well, we are coming to the end of the time. I want to give one more opportunity for participants on the phone line to ask a question. You can do that now, and if not, we will close out.
I had a quick question. Whether or not you have multidisciplinary staff from your primary care network working in your clinic, and you mentioned the staff in your clinic, or human staff, but are there other staff like pharmacists or nurses who are working on the process with you?
We have a pharmacist, nurse, behavioral consultant. That's pretty much it right now. Anyways, they haven't really been doing the screening with us. We're actually, the chronic disease nurses, we're going to be working on the next level of patient, the higher risk patients, than just regular screening. She'll be doing our complex care plan. So that's what we're working on right now is getting patients in that should be doing that. So they're getting their complex care. The pharmacist, she's only in a half day a week. It's not something we've done with her. She's aware of it, but I haven't actually introduced that to her as something I expect her to do. But the complex care plan, like I say, we're using that for our nurse, and because we see her as the one-on-one who's helping these people that are higher risk. But as the regular, large panel screening, it's mostly my staff are doing that, and then the doctor opens that screening tool, presses select recent values, and then just fills in any blanks that aren't filled in.
Well, that's great. You're using them for that downstream work. Great. Thank you.
You're welcome.
Any more questions? Well, on that then, I will thank Dr. Walsh very much on behalf of TOP and other clinics in Alberta for sharing your work. I'd really like to thank Brad Reben from QHR Accuro for participating today as well, seeing what Dr. Walsh has done, and also for understanding and helping us understand how clinics can get access to the CDM worksheets and get them installed and configured for their clinic. And on that note, I will sign off and thank everybody for participating and wish you a good afternoon.
Thank you.